So I did put on a study guide for you guys. The next week we have the third exam, exam 3. And so here's this week. So we had the quiz. Here's the PowerPoint that, like I said, before we had a guest lecture come in, that was the PowerPoint that Holly and probably Amy used as well. But the guest PowerPoint is beefed up a little bit with the pharm expertise. So they're very similar, but there's just, so you can really, there's not a lot of difference. Some of our guest PowerPoints are quite different from like my PowerPoint, because I'll do more just pathophysiology stuff, but these are a little bit closer. But so you can really, for the exam, you can study off of both of them like typical, but there's less differences. And then here is the study guide down at the bottom. And the way I recommend using it is when it asks for a topic and it says per the PowerPoint, for example, mechanism of action for the drugs used to treat Alzheimer's disease, go into the PowerPoint and look at what it says. So I just can't stress that enough, is questions are usually coming from PowerPoint. So if it's asking something, go into the PowerPoint and find that verbiage that matches up with that and see everything that it's talking about. And the question is going to be somewhere in there. So this is about 2 pages of tips of what to study. And if you have questions, you can always ask me, but this is a lot of it. I'll say like per the PowerPoint. So really utilize this and match it up with the material that you've been given. And remember, you have to use both. Like if we had a guest speaker, typically, though this week is a little different, but typically you have to go by both PowerPoints. The material will be on both, but usually more of the drug material is from our guest speakers. So I'm going to pull up the other PowerPoint today for our guest here. Did you have a more updated one, or you're just going to talk off of? Do you want to? You can do it differently if you want to. Do you want to email it? The only thing is if I do Zoom on here, oftentimes I lose the recording, but if I do it on here, but do you want to download, and that way you can have what you feel most comfortable using. Thank you so much for coming. I'm sorry that I didn't communicate earlier in the semester. We have a pointer too. And then we have a microphone. I don't usually use it. Yeah, and some of the instructors do, and I don't, and it seems like they can hear me fine, so.
Oh, it was like, or just like uploaded it.
Is it? I know sometimes the internet just stalls out, doesn't it? Like it's been less reliable, it feels like.
Yeah, it has.
It's been quirky. Oh, there it is. Okay. So let me just open it up for you. So they'll see that one. It's already recording. So you should be, oh, let me just pull you up the right. There you go. And then you can move that wherever you want it to. You know how it is. Yeah. It's just, it's weird being in someone else's house, you know what I mean? And I don't know. But I don't know if you want that or not, but there's the pointer for you. Okay, Rachel, let's do you like to go by Dana, or do they call you Dr.
They call me Dr. Dana because they don't even
Dr.
try.
Dana. Dr. Dana. Thank you, Dr. Dana. Okay.
Oh, yeah. All right, so good morning. Oh, we knocked. Okay. So yeah, good morning. I'm Dana Valcortez. I teach upstairs in the School of Pharmacy. My training, so I actually specialize in toxicology over at the Oregon Poison Center. But I'm not going to tell you like all about that because it's cool, it's fun, and if you ever have issues, we do get calls from like dentist office and stuff periodically when there are issues, particularly with local anesthetics sometimes, but that's a whole nother thing. So today we're going to talk about medications for pain management, sedation, and anesthesia.
Oh, that one's for this one. Yeah. But this might need to.
Okay, so as far as objectives, basic, just defining pain, classifying pain based off of severity. Talk about the two different types of pain. So we have nociceptive, which is what we typically think of, and then neuropathic, which is not something you'll probably be dealing with so much, and it's treated a completely different way that we will not be talking about. I will talk about some of the common medications used in mild, moderate, severe pain, and then basic pharmacology for those analgesics, the ones that we are going to use the most often for dental pain. So things to keep in mind: mechanism of action, side effects, and any cautions, kind of figuring out which patients some of those drugs might be best for or to avoid. Other objectives, so important things are maximum daily doses of acetaminophen and ibuprofen, but really acetaminophen or Tylenol. That's the one that when we hit those max daily doses or somebody's taking too much for a long period of time, that we really have serious consequences. Other objectives, so being able to recommend an appropriate treatment strategy to reduce the risk of opioid abuse or misuse, as well as to reduce side effects. Being able to identify signs of opioid overdose, explaining how to administer Narcan, which is going to be different depending on the setting. And then as well as talking about the 4 just general stages of general anesthesia. I'll kind of go through this table of contents just step by step to help. So have an idea of where we're at, but we'll start with an overview of pain. So pain, I think most of us should all be familiar with it, but it's an unpleasant sensory and emotional response to either actual like tissue damage or potential tissue damage, or perceived in one way or another by the body, by your nerves, by your neurons, whether it's real or not, whether there's actual damage occurring. And it's described in those terms. So we have pain, we have acute and chronic, which we'll define in a moment, as well as within chronic, there's more of like the nociceptive versus neuropathic. So neuropathic being nerves, neurons, and nociceptive being more of a like somatic, actual, think of like tissue, as opposed to just the neurons that are transmitting those signals. And then neuropathic, similar to our neurons, we can have both centrally acting, something that's kind of coming from the brain and causing that pain elsewhere in the body, or it can actually be in those like nerve terminals. So you could have neuropathic pain like in your fingertips and toes. That's a common thing that comes up with diabetes. Or it could be something that you have nerve damage in your spinal cord that is causing pain elsewhere in your body. And so it's not really happening in the location. Some pathophysiology, I didn't go into too much, but really we have a two-way signal system. So signals are going from everywhere in your body and transmitting to the brain and saying, hey, something's going on. The brain's like, all right, that's not good. And so we're sending that pain signal back to the body. And so you do have this two-way. The brain can send those pain signals when it's not receiving something peripherally. And sometimes it doesn't respond appropriately to other signals it's getting. If you've ever noticed that like really, really hot water and like really, really cold water kind of feel the same right away, that's kind of along the same lines and very similar with pain, is that things that are more extreme kind of get mixed up a little bit, especially immediately. And so sometimes things that are painful or are not don't always get exactly the right signal. And sometimes that can become more of a common occurrence in certain individuals, which is how we get to, some of these things where nothing's really happening, but they're still feeling pain. Got a big picture, but we're going to break this down and make it actually a little bit visible. So starting from, depending on where you're at, there's different ways to try and combat or treat pain. And so it does make a little bit of a difference what kind of pain you're talking about and how to treat it. Opioids kind of get used for almost everything anymore. And it's not always appropriate. They don't always actually work, depending on the type of pain we're talking about. And so it actually, like, there isn't one thing that fits all. Some of it, so perception, again, your brain taking those signals from elsewhere in the body and recognizing it as pain. We can treat that with opioids. We can also use alpha-2 agonists, so clonidine or dexmedetomidine are two alpha-2 agonists. General anesthetics are going to work there. Modulation, so kind of along the actual pathways. Again, opioids and alpha-2 agonists. This is also where NMDA antagonists, so ketamine, is the one that I don't know if you guys see it in practices much, and it was not in the previous slide, so I'm not going to actually be talking about it, but that's where this fits in. Ketamine is getting more widely used recently in like emergency medicine and for procedures because it does have both pain control as well as like the anxiety and sedation properties. So it can help relieve anxiety and sedation. So it kind of helps with everything at once instead of having to treat separately with like a benzodiazepine for anxiety or sedation and then an opioid for pain, which has its own sets of problems. The actual transmission, so along those nerve fibers, so getting from the signals in the periphery up to the brain, that's going to be anesthetics, but we're talking local anesthetics now, as well as opioids. And then the actual like pain receptors that are in your arm or your fingers that are noticing something's going on, that's going to be our NSAIDs, potentially antihistamines. Antihistamines work fantastic for bone pain caused in patients that are being treated with chemotherapy. Like, why in the world would that do anything? But they do. Again, opioids may work here, as well as sticking with the local anesthetics instead of general anesthesia. Depending, so if it actually is that nerve that has some damage, opioids aren't going to work on that. They don't help any misfiring or like kind of misinformation in the tips of those nerves. So any sort of neuropathic pain, which unfortunately gets treated with opioids a lot. Also, when we get to chronic pain, opioids, studies show they also don't work very great. So even if it does have a use in the early on in a disease process, as time goes on, the opioids really don't have the intended effect. So it can to increase doses, and really a different method would probably be more effective. There's a lot of ways to assess pain. Pain is obviously subjective. Yes. They can. Some individuals are more susceptible to others with opioids actually making something more sensitive to pain. And they can actually become oversensitized so that like lots of things feel painful. That's not everybody. We can't predict who it's going to be. And it tends to be in much longer chronic use. But that can be something in patients that are chronic users or potentially with like a chronic use for addiction, for like as opposed to therapeutic use as well. But that's much less, I'd say less common than a lot of the other issues that we see. But it can compound the problem. There's a number of ways to assess pain. Some are better, or like a straight boring line is kind of like not that fun. And you just kind of, again, ask somebody where on the line, no pain, worst pain you've ever felt in your life. Using scores from 1 to 10, kind of specifying whether pain, where mild or moderate or severe pain might fall on that line. But pain is completely subjective. You can't tell if somebody is, telling you the truth about their pain, and what the exact same process could feel like a 7 in one person and a 3 in somebody else. I know individuals who have gone into surgery and came out and were prescribed really massive painkillers, and they got home and they took like an over-the-counter Tylenol, and that was all they needed. I've been in the hospital myself and been told, like, are you really in that much pain? Because I didn't look like it. And I was, my blood pressure was fine. I was like trying to sleep. And it turned out I had some necrosis going on and was in like actually really severe pain, but you don't look like it. So it's really, really difficult, unfortunately, to tell what's actually going on. Other ways, especially kids, we like to use the faces. The classic faces, they're long Baker. I guess it took 2 people to come up with them. Again, a lot of times they're paired with a scale of 1 to 10. We'll also sometimes use colors or more simplified faces. And then we also have not what you'll probably use, but in individuals that are not readily able to communicate. So if somebody's nonverbal, faces work very well, or pointing at a line. But individuals that aren't even able to do that, I pulled these from what we use in critical care, not necessarily the exact scale you may use, but there are things like looking at their face and seeing if, there's like furrowing or if it's more relaxed. If there's like actual grimacing, you can look at things like blood pressure and heart rate, particularly for something that's acute. People get used to pain. And so their vitals may not change very much. Whether or not somebody can move very well, whether they're kind of, again, not like grimacing with your hands, like you're kind of just like really just like squeezing. Just other ways that you can tell kind of to help along in somebody that's unable to communicate with you. And again, that's not always going to correlate exactly with what the patient is reporting. If you're trying to kind of, maybe you aren't so sure that the patient is telling you the truth or are worried about opioid seeking behaviors, it's not, we can't unfortunately very well identify who's actually in pain and who is not. So nociceptive pain, this is normal, what we most of the time think about. So this is, again, actual or potential injury to our tissues, bones, joints, muscles, connective tissue, everything outside of our actual nervous system. It usually happens pretty fast. It's not there and then it is. Somatic pain, our musculoskeletal pain, tends to be very sharp, localized. There is a place that is injured and it hurts. Visceral pain is more of like something's going on internally and you don't actually have pain receptors there, but the brain knows something is going on, so it's still sending pain signals to you. And it tends to be a little bit more spread out area because there isn't a specific, like if your liver is sad, there isn't a specific place that, there's injury occurring. And so you might feel like a wide area in your abdomen that just doesn't feel right, but it's not going to be necessarily like a pinpoint, like when you hurt your ankle, like out running, you know exactly where that is. And so that's going to be different. The other thing with visceral pain is that it doesn't always really line up with location. So that's why with like heart attacks, you feel pain radiating down their arm. There's nothing happening in their arm. But again, our brain isn't always perfectly tuned in that they know something's going on, but it's sending that pain signal to kind of the general area. It's just not perfect. We also see that that's different in men and women. Men have that going down the arm. Women usually don't. And so it's easy for women to get sent home from the emergency department because they don't have those classic signs. Classic being when we only studied like white males. And so there are other places that can hurt as opposed to the actual spot that the pain is occurring. Neuropathic pain, not something that you guys would necessarily be treating, but you may see in patients. So this is, again, damage or dysfunction of the actual like nervous system. Very often in the periphery, sometimes it can also be central. This tends to be described more as like burning or tingling. Sometimes it can be more of like a shock and like an instantaneous, you kind of feel it. And then if you like touch something, oh, you feel it again. Or like it's kind of being stabbed, but it's not like you just have shocks going off usually. But anytime there's any pressure on activation of that nerve, it's very difficult to treat. Lots of patients get treated inappropriately. Opioids aren't going to do anything for this. Acetaminophen, ibuprofen, not going to do anything. There are medications that help. They're not super great. And even with treatment, this is not a pain that we can typically have go away, but we can at least make it patients a little bit, easier for them to function, get through their daily lives. Really common is going to be patients with uncontrolled diabetes. We want to prevent it because, again, we can't completely make that pain go away. You'll also see it in, yes, absolutely. Gabapentin really should be first line. And most of the time it is, but depending on who is treating and what the initial diagnosis is, it's not always prescribed. We'll see it in diabetes, patients with shingles, so herpes zoster, fibromyalgia, some cancer and chemotherapy pain, although a lot of cancer pain is more somatic. Any sort of like spinal cord injuries or like physical damage to the nerves. Anybody that's had an amputation has phantom limb pain. Certain infectious diseases. So there can be neuropathy in HIV patients caused by the medications that they take. Patients that have Lyme disease that goes unnoticed, untreated for a long time can end up having nerve damage. And so they have peripheral neuropathy. As far as classifying, so we're breaking down further into acute and chronic. Chronic we define as being greater than 3 months of occurrence. And then within chronic, that's either cancer or non-cancer pain. They get treated differently, partially because of the etiology, but as well as what treatments work. Opioids were originally, especially like our long-acting opioids, were originally approved just to treat cancer pain as far as chronic. So acute injury and then chronic cancer pain. And then the opioid crisis that probably have heard about was because there's a lot of marketing for non-cancer pain. And so again, patients across the board were being treated for chronic conditions that opioids were not necessarily the best treatment option for. Within malignant pain or pain caused by cancer, that can also be chronic and acute. Tends to be chronic, but maybe like some spikes of acute in between. And that's going to be both from the disease, but as well as treatment, diagnostic procedures. There's a lot of things that go into that. As far as differentiating between acute and chronic, other than time, acute pain is not as common for somebody to develop dependence or tolerance. It's absolutely possible, especially in individuals that have other dependencies. So people that have like one dependency just naturally tend to have whatever underlying, we don't entirely know what, but they have some sort of predisposition. So that can be more likely to potentially have some dependence that it occurs in acute pain, but it's much more common in chronic pain. Tolerance takes time. And so that's not going to really occur until you have somebody that's being treated chronically. The psychological component, really we're going to be talking about chronic pain, and it becomes a problem because they feel dependent upon being treated for their pain constantly, separate from the actual pain signals that are being sent from wherever in their body to the brain. They also have like that feeling of needing it. Chronic pain doesn't always have that cause that we can identify. It can be more psychological as opposed to an actual process that occurred to cause damage or potentially cause damage. In acute pain, we're really trying to reduce pain. Making sure patients realize they're not necessarily going to be pain-free, but it should be better. And we'll try and get them to be close to pain-free and for it at least to be tolerable. In chronic pain, yes, we're trying to make the pain better, but really at that point, we're focusing on their ability to function. So not looking at the pain scales as much, but quality of life, and is the pain preventing them from doing things in day-to-day, or are there things that they need to be able to do that they can't, whether it's walking, just getting around the house, being able to stand while they're cooking, or other form like exercise, those sorts of things. And then comorbid, any chronic conditions. So this can be psychiatric conditions. It can also be like diabetes with peripheral neuropathy. In acute pain, generally, these are going to be unrelated. And chronic pain, very often there's going to be something there. Obviously, if you have osteoporosis and you fall and break your hip and now have acute pain, yeah, your osteoporosis played a role there. But it's kind of led to that initial act, but it's not actually involved in the current pain itself. Versus in chronic pain, that diabetes that caused the peripheral neuropathy is really still there and going on. Risks for developing chronic pain. So there is some genetic predisposition. Patients that have a low pain threshold. So again, like we have different experiences, but somebody that feels like a higher pain scale for something that other people generally have a much lower pain score for. There are centrally sensitized conditions. So similar to patients who maybe are on opioids continuously and end up becoming sensitized, there are other processes like fibromyalgia that can sensitize the body so that when you do have some sort of stimulus that is painful, it sends off like bigger alarm bells than it should. For any sort of surgical procedure, the type of surgery is going to make a big difference as far as whether or not it's at risk for causing chronic pain or for the patient continuing to have chronic pain afterwards. So things like an amputation, mastectomy, like an arthroplasty, so cleaning out all that gunk from somebody's arthritic knee. Those are going to have a real high risk of still having pain afterwards at some level. Dental surgeries generally shouldn't be having any pain chronically afterwards. And it's also important for surgery for post-operative pain control. And we know that it's going to be painful. So treating that pain before the patient's able to tell us they're in pain and kind of getting ahead of it. Things that also can kind of lead to like that lower pain threshold. So having anxiety and depression, and particularly like not just being diagnosed, but being in like a period of time where you have higher anxiety or a higher level of depression, fatigue, anger, higher thresholds, feeling better in general, being rested, understanding some of that pathophysiology or just what's going on and causing the pain. Understanding can make you feel better. Apparently yelling swear words actually literally makes you feel less pain. There's some studies that have come out recently. So if your parents always told you bad words, there's actually some benefit sometimes. Yeah. Right. So, so starting the meds, Tylenol, acetaminophen, and all of our NSAIDs. That's our bread and butter. Acetaminophen comes in lots and lots of combination products. Fortunately, this is probably like 10, 12 years ago, APAP is not allowed to be written on medication labels anymore because patients saw APAP and they saw acetaminophen and did not know they were the same thing. Yeah. What is APAP? APAP stands for amino para acetyl. Oh.
Do we need to know?
Nope.
Okay.
Yeah. Let me think. So in the US, it's acetaminophen. Elsewhere in the world, it's usually paracetamol. Amino para acetophenol. Yeah, something like that. It's those four in some order. There's two A's and P's. Putting me on the spot here. So fortunately, APAP is not allowed to be written singularly on labels anymore. So it makes it a little bit easier for patients to realize, because there's tons of combo products out there, cough and cold, like sleep products, why you need like acetaminophen along with your diphenhydramine to sleep. Not that you should be really using diphenhydramine to sleep anyway, but like that's what Tylenol PM is. And if they're taking that and they're using it because they can't sleep, because they're sick, and so they're taking cough and cold products, and then they also have some other injury recently and they're taking their pain medication, and oh, well, I'm taking that, but I'm sure I can just take over-the-counter Tylenol too, and it starts adding up very, very quickly without necessarily realizing it. So those combination products, education is really important. Yeah. So it's, I would say taking Tylenol PM to sleep, if it works and you don't do it on a regular basis. The problem with Tylenol PM is that, so diphenhydramine can have the opposite effect and actually make you really alert and unable to sleep. You see that in kids, like, you know, like you're not, well, used to be able, be allowed to give it to kids. Now you're not supposed to give it to kids under 6, but if you give, like give their kid like Benadryl to go on a plane and they'd go like nuts instead of sleeping. And it's because they're anticholinergic. And so at low doses, they have the antihistamine effect predominates, and so you get really sleepy. But it doesn't take much to kind of flip over and get to the point where you're like wired. You also, it doesn't do that for you. There can be some, not dependence, but your body just becomes dependent on a sleep aid. So it's good to avoid doing it constantly, because you can kind of have like a almost like a dependence, more of a psychological dependence that you need to take something to sleep. But yeah. So personally, I don't deal with prescribers like at all. I deal with people who are doing things usually that they shouldn't. And sometimes that just, yeah, bad things happen, but that's absolutely one of the big reasons. And the pushes for medical marijuana is to cut back on opioid requirements. And we'll talk about like multimodal pain control kind of the end. The more ways you try to control pain, the multiple pathways, you tend to do a better job, as well as needing less of everything. So lower doses of everything means less side effects from all of those things, and hopefully better control in general. But pain control is definitely one of the reasons that medical marijuana is prescribed. There's not great evidence, but that's also because we're not allowed to study it, because it's a C1. And so, yeah, it might work, but we're like, scientists are literally not allowed. They'll lose all their funding. Yeah, if you for like not realizing you're in pain or forgetting you're in pain is absolutely a thing. Like, that works.
I just had a quick question. So on the old
Yeah.
Opioid consumption, is that still true?
Yeah, I think it's on like the next slide. Or NSAIDs as well as acetaminophen can reduce your opioid requirements. So acetaminophen, we don't really know how it works, but it's been around like forever. There's something to do with prostaglandins, we think, but it does not have anti-inflammatory and it does not have anti-platelet effects. So some of the things that differentiate it from NSAIDs. Generally safe until you get to too high of doses. Most effective in quotation. Some people swear it doesn't work for anything, and other people are like, oh yeah, it works just fine. Arthritis, like headaches, acute pain, fever, definitely works for fever. And so it's good for that. Some other, so side effects, some GI, but not really that much compared to especially NSAIDs. The big thing is liver toxicity. Combination drugs, you kind of add up, get too much acetaminophen, taking too much at once or over a 24-hour period, or taking too much, too much over an extended period of time. In general, at the Poison Center, we are really concerned about people that take more than 10 grams at once, or we send them in much sooner than that, but 10 grams is where we're starting to be real concerned. If you're taking like 4 grams, there's potential that if you're taking that every day for like a month, you can get in trouble. I've also had patients that were taking 1 gram every 3 hours for dental pain, actually, and then ended up the next day because somebody told them that you're really not supposed to do that. And it had been, I believe, 48 hours. So 8 grams a day for 40 hours, and they did require treatment for Tylenol toxicity. Fortunately, we have treatment for acetaminophen. The treatment works much better for like a single overdose, and when it is shortly after the time of overdose, but it also works for chronic. We just don't know exactly the best treatment, the best treatment protocol for that. With alcohol, so somebody that drinks alcohol frequently, regularly, they are more likely to produce the toxic metabolite of acetaminophen. Typical dosing, 650 to a gram every 4 to 6 hours, but we don't want to go over 4 grams a day. And if somebody has any sort of liver dysfunction, or if they are a heavy alcohol user, so 3 or more drinks daily, then we want to cut them and keep them down to 3. We tell patients kind of on lower levels, but when you're actually treating or when you're telling a patient, then it's under advisement, and you can go up to those higher doses, especially when you're not having them do this forever. Pediatric dosing, 10 to 15 milligrams per kilo, also every 4 to 6. NSAIDs inhibit COX, and that leads to inhibition of prostaglandin synthesis. So we have a decrease in inflammation and pain. Again, still works for arthritis and fever, gout, menstrual pain, minor to moderate acute pain, sometimes back pain, depending on the mechanism. COX-1 and COX-2. So COX-1 is more of the affects the kidneys. So after somebody's taking NSAIDs, or somebody has kidney injury, we want them to avoid NSAIDs. That's also what protects your stomach, because prostaglandins make that mucus lining. And so if you're blocking that, you don't have mucus protecting your stomach from your stomach acid. And it also has an effect on platelets, so you're not going to clot as well. Versus COX-2 has an effect that's where our real pain effects come from, the inflammation, fever, and then a little bit of homeostatic, like just general, homeostatic effects. We tried to target COX-2, and that's where like Celebrex, celecoxib came in, and it wasn't exactly the greatness that we were hoping, and there was an increase in cardiac effects, negative cardiac effects. So kind of breaking down into organ systems, the adverse effects in the stomach, you're not going to produce the mucus, as well as the bicarb that helps kind of keep the pH regulated. So your stomach acid is directly attacking the stomach lining. So there is a risk for ulcers, perforation, GI bleed. Tends to be with chronic use. You're not going to get a GI bleed just by taking a bunch of an NSAID at once. Aspirin in particular itself can cause damage. And so it has like both effects. It can cause damage as well as decreasing the mucus production. So in chronic use, especially at higher doses, only old people, I feel like, use aspirin for pain control anymore. Most people like use better things. Aspirin for pain control?
Or like even
Oh, no, definitely for antithrombotic. It's definitely useful after patients have had a cardiac event, so like after a stroke or heart attack. There is definitive evidence that low dose aspirin is going to benefit. There's no difference between a baby aspirin and a full size, like 325 aspirin. And there's no benefit to prevent if you haven't had an event yet. That was more recent that came out. So you don't want to take something preventively, but once you've had something, again, usually stroke or heart attack, then it can help so you don't have another one. Yeah. Cardiac, so some increases in blood pressure, some increase of thrombotic events from the COX-2 pathway. So there is a small increased risk of heart attack and stroke, particularly in certain NSAIDs, but it is a very smaller risk. Kidneys, so you can have sodium and fluid retention, electrolyte abnormalities, and risk for acute kidney failure or acute kidney injury. And this can happen after single doses. Patients that already have some sort of kidney dysfunction are at risk of their kidneys worsening temporarily, which in some patients can make a difference. And that like short little bump can cause some real problems. And then it also inhibits platelet aggregation. They bind irreversibly. So once those platelets are bound and can no longer, stick together, it's like a month before they're completely back to normal. And so there is an increased bleed risk. Not the same as other antiplatelet or anticoagulants, but it is there. Ibuprofen, probably the biggest mainstay. So Advil or Motrin typically is 200 to 400 milligrams every 4 to 6 hours. That's our over the counter. You don't want to go over 3.2 grams per day. But like secret, if you do, nothing's really gonna happen. Poison Center, we don't really care about NSAID overdoses unless they're massive. You might feel real crappy. It's just not gonna help, and you're more likely to have some of those side effects. So sticking below those max doses, you want your patient to have pain control, not just keep taking more and more and not having adequate and not having their pain controlled. Pediatric dosing for this is 5 to 10 mg per kilo every 6 to 8. Lots of NSAIDs. So aspirin, obviously ibuprofen, but also naproxen. Those are ones that are available over the counter. Ketorolac is the one that is available for both IV and IM. I remember I think I was in high school and I was injured and they called it super ibuprofen because it's IV. Ibuprofen itself is actually available IV now, but you have to give it over 30 minutes and it's super expensive and just kind of a pain. So ketorolac is pretty much what you would see in somebody that can't take oral. Celecoxib is like our COX-2 specific, so we have increased CV risk, but generally well tolerated other than maybe some GI upset or long-term GI effects with chronic use. Sometimes it'll be like super ibuprofen because it's IV and it's stronger. It tends to be used in like an emergency department or like for pain that over-the-counter dosing isn't going to work, but an NSAID still probably will. It's going to be faster because you can give it IV. And so it also kind of lets you know, do I need to move on to something stronger or is this good instead of waiting like half hour to an hour for them to absorb whatever you're giving them orally. Opioids, we have natural and synthetic coming from the poppy, natural ones coming from the poppy. Effective for a lot of types of pain, but not all of them. And they bind to the opioid receptors in the CNS, so they inhibit the transmission of the actual pain impulse as well as inhibit those pathways. So kind of on both directions, those signal transmissions. There are multiple types of opioid receptors. We don't have drugs for all of them, but we're, science is trying to understand a little bit better what all of these do, as well as potentially target them for better treatment of different things. But really the mu receptor is what we're talking about when we talk about opioids. So that is our analgesia, sedation, leads to decreased blood pressure, potentially itching, nausea, the euphoria, decreased respiratory drive, the constipation, all of that is mu. Delta, kappa, and sigma. Sigma is interesting because like cough syrups that have codeine in them, it actually does suppress cough. That is an effect. Now, giving codeine for a cough, especially in the middle of an opioid epidemic, but it does work, and it's been around for a really long time because it's a natural product.
Are we talking about the overdose of opioid or the side effects in general?
Side effects in general. So separating like mu, kappa, our opioid receptors kind of have all of these different targets on them. So depending on the compound, it may target a different one of these, and they have different downstream effects and kind of send out different signals. Lots of opioids, oxycodone, oxycodone with acetaminophen, hydrocodone with acetaminophen. There's a long-acting plain hydrocodone, morphine, hydromorphone, codeine, fentanyl, heroin. Codeine itself is not active. It gets metabolized to morphine. Just give morphine. People have different ways that they metabolize. And so some people don't metabolize it quickly. And so they don't have morphine in their system. And it takes forever or really high doses to give them pain control. Versus other people may metabolize it really, really quickly. And so they have a ton of morphine in their system very quickly. This is incredibly a really very big issue in pregnant patients when mom and baby metabolize it differently. And there have been a few infant deaths from codeine in breast milk where baby metabolized real fast and changed all that codeine into morphine because mom needed higher doses. She wasn't getting pain control. Codeine, not a good drug. As far as adverse effects, respiratory depression, it's respiratory rate. And it actually is your body, you can't recognize your carbon dioxide levels going up. So you don't feel the need to breathe. It does not, you don't become tolerant to that. So as patients need higher doses of pain control for like a chronic condition, they need higher doses for the pain, but it's going to be the same dose that leads to respiratory depression. So once you start getting higher, you're more and more likely to potentially have dangerously low respiratory rate. Constipation also does not decrease in time. It actually affects your bowel movement. Giving a stool softener will not help. It will just make everything mushy, but it's not going to come out. So giving patients that are on any sort of, even like just for a few days, giving them some sort of stimulant to help keep things moving, because it can be quite uncomfortable if they're unable to have a bowel movement. Nausea and vomiting, basically over time, tolerance and dependence, the potential for addiction and abuse. Histamine release. A allergic release of histamine. Morphine in particular is well known for this. It directly stimulates the release of histamine. So it's like you're having an allergic reaction. You're just not. Typically, it's not gonna be like an anaphylactic type reaction. Usually it's more itching, a rash or hives, but there is the potential for some for bronchospasm. And then chronic use, potentially hypogonadism. So depression, sexual dysfunction, potentially amenorrhea. So real allergies to opioids are rare, but you'll see in charts all the time. Usually it says nausea and vomiting, which is not an allergy anyway, but it's really not even that much of an intolerance. If you take it with food, most of the time that's going to improve things. And there's all kinds of other things that can impact like nausea and vomiting, like pain. Like I said, that histamine release is a direct action, typically by morphine. So a different opioid, most often you can use and not have that effect. Chronic use, neonatal opioid withdrawal. So we don't want pregnant women to be using this chronically. However, opioids are actually safer than most other pain controls in pregnancy. NSAIDs are risky because they can close the ductus arteriosus. So when babies, like before they're born, there's like a hole in their heart, and normally it closes right around the time they're born. If it closes early, badness happens. I don't really know, but it's not good. Tylenol can cause some birth defects. That one's particularly early in pregnancy. But for the rest of it, it's generally safe. But opioids in small doses for acute pain are safer than the pain itself, because vomiting and distress from pain can cause harm. So it is categorized. So, you know, the letters for pregnancy categories, it's a C, but it's better than like pain would probably be like a C or D, depending on how bad it is. We have the risk of excess sedation, respiratory depression, lead to coma and death, especially with any other CNS depressants, which includes benzos and alcohol. And I'll talk about that a little bit when we get to benzos. Being careful in patients with liver and kidney impairment, because they're not going to clear it as easily. And so sticking with lower doses, further apart. Older patients, they tend to have kidney injury or some sort of kidney impairment. And you don't want those to kind of build up, and then all of a sudden you have a whole bunch of extra drug in their system and you're just waiting for it to clear. To remember all of the different effects, SUV PAR is a mnemonic, so sedation, euphoria, vasodilation, it's where we get decreased blood pressure, constipation, the analgesia, respiratory depression, which is our big one that we're worried about, particularly in overdose, as well as reducing cough. To reverse them, you give naloxone. Yeah. Yes. So for opioid overdose, the respiratory depression, so you're not getting oxygen, so you're not sending oxygen to your body. There are lots of other effects of opioids, but they're not going to be the thing that kills you. The just lack of oxygen because you're not breathing is going to be the thing that kills you. Sometimes we'll hear in the emergency department, like somebody got naloxone because like they were found down and their pupils were super small. Yeah, opioids make your pupils really small, but if they're not breathing slowly, then opioids aren't the cause and naloxone isn't going to help. So really it should be treating with naloxone because their respiratory rate is low. If the respiratory rate is up, is high, there's something else going on.
So it's not the first thing you want to notice if breathing slow. That's really different.
Yes. Slow keeping an eye on the respiratory rate is going to be probably the most important thing. It's also going to be the thing to like warn family members about for somebody that is at risk of potentially overdosing, or if they have like a kid or somebody at home that may get into their own meds, and letting them know. More and more recently, there's been a push to get naloxone prescribed to just about everybody with an opioid prescription. Pharmacists are allowed to prescribe it at the pharmacy in most states, if not all now. And so it's available. Unfortunately, it's usually pretty expensive and insurance doesn't always cover it. But there's a lot of different ways. In a healthcare setting, most likely it would be the actual IV or IM form that's available, but it may also be like a nasal spray. So it is a prescription, but yeah, so it is technically a prescription, but like the state Surgeon General wrote a prescription that for anybody that pharmacists can fill. So a lot of pharmacists will ask or say something if there's a new prescription, especially if it's a high dose or for like a chronic use. Patients can also request it. Family members can request it. You don't have to have an opioid prescription yourself in order to get a naloxone prescription filled.
Like, all the fentanyl and stuff. That helps.
Yes, so naloxone absolutely helps with fentanyl. Fentanyl, so there's a ton of stories out there. Healthcare providers or EMS, police are not overdosing from like fentanyl dust. That's completely myth. It tends, their respiratory rates tend to be perfectly fine, but symptoms are essentially anxiety attacks. It takes a whole bunch of fentanyl. Like you would have to cover like the palm of your hand with fentanyl patches, which are made to be absorbed through your skin. And it would still take like 5 hours before you get enough to like drop. So you're not absorbing it through your skin. It is not absorbed GI. We can't like swallow fentanyl. That's why it's not available orally. So it's for first responders, that's not an issue. For patients that have fentanyl, a lot of times other things are also mixed in. So particularly when some sort of benzodiazepine is in there, usually patients have no idea what's in there in the first place. But when there's a benzodiazepine, that's when naloxone is going to be tricky because it's not actually treating everything. But normally a regular fentanyl overdose, so somebody who has some sort of like heroin use and there's not like a benzo cut in, naloxone is going to work just fine.
That's great. I have kids and like I have a teenager now and she wants to go to parties and I don't know what's at parties, but be around it and like breathe and die. I don't know.
Fortunately, no. But there's definitely like there are things that look like prescription medications that are completely just fentanyl. There are ones that look like benzos that end up being fentanyl. There's cocaine that has fentanyl in it. Like why? Like it's kind of all over the place, unfortunately. I have instructions here for how to use the nasal spray for reference. As far as choosing the therapy, lots of things can go into that choice. So how old the patient is, how concerned you are about misuse, cost, the big one, any other conditions the patient has, what their quality of life or what your goal for quality of life may be, their risk of adverse effects, and if they may be worse if they occur in certain patients, as well as the actual efficacy of the medications. And multimodal pain management. So I came up a little bit earlier, but trying to target different aspects of the pain itself. So things that are medications as well as non-medication. So like physical therapy, Psychotherapy can be useful, acupuncture, music therapy. There's a lot of things that can help. And then within medications, targeting, okay, let's target the inflammation. Let's target perhaps with an opioid. And now we're getting two mechanisms of action, and together, hopefully, we should be able to have a lower dose of each than what would be required if we just used one or the other. And then you'd have a higher dose of that one or the other and more likely to have negative side effects. Mostly we're concerned about the opioids for that, wanting that lower dose. But having a lower dose of NSAIDs also can be less GI upset or less likely to develop some sort of GI adverse effect or cardiac adverse effect. So mild pain, muscle soreness, a headache, acetaminophen, NSAIDs at just regular over-the-counter dosing. When we get to more moderate pain, potentially still over-the-counter dosing, but we also have prescription strength, so kind of increasing that max dose of Tylenol up to 4 grams per day, and we have higher strength. NSAIDs available, naproxen is available over the counter as either a 200 or 220. Prescription, it's available 500 or 550. So it's like over the counter ends up being 400 or 440 versus 500 or 550. Not a huge difference. And then all of the other NSAIDs that are only available prescription. And then for things that either the pain does not go away with that initial treatment, or that's more severe in the first place, that's when something like opioids are going to be considered. So I am definitely not an expert at this, but like what would fit into each of these categories for like some sort of dental pain? Like draining and abscess, extractions, yeah, absolutely. Having that pressure.
I had that, and they gave me like Vicodin, and it didn't help, but like I took an NSAID, and it was like it worked so much better.
Yeah, so sometimes like the opioids, the NSAID is going to actually help with the swelling as well as like your immune response. And so again, kind of decreasing all of that flow of your immune system versus the opioid's not going to do that at all. So it does make a difference. Recommendations. So if you know something's painful, it's better to take like a regularly scheduled. So take that Tylenol every 6 hours, or take your naproxen every 8 to 12 instead of waiting for the pain to kick back in and treating it again then. Once the pain starts, you don't want to, you kind of get behind the 8 ball a little bit. So having that scheduled dosing, especially again, a shorter term, but even somebody that has chronic and severe pain, you want to have like a baseline, that kind of pain management, and then you have little doses for breakthrough. So kind of a long, kind of steady treatment to prevent like really severe pain constantly, and then anything extra they can treat later. Keeping things simple. We don't want to get confusing, making it easier to either take too much or not enough. We want to stick with oral meds when we can. They last longer. They don't have as quick of an onset, but they last longer. Oral opioids last longer than IV. Morphine orally and lasts longer than IV morphine. Yes, because so in the body, when you take an oral medication, it takes time to dissolve and get absorbed. And so that entire time, you're getting dosing of that morphine essentially continuously from your gut until you absorbed it all, as opposed to you get a shot and that's it. And it's so that shot will be for less time because all of it starts getting metabolized right away, versus orally it waits until then, like all of like each bit of morphine gets absorbed before it can start to be metabolized. Give medications preemptively. So if you know something like a procedure is going to be painful in the hospital. Like if somebody is in pain, we're gonna have to like turn them or do something, give them pain control ahead of time, give the lowest dose for the shortest duration of time necessary. And again, trying to hit all of those multimodal methods of therapy. Some terminology, tolerance is the reduction in the drug's effect over time because you've been exposed. That does not mean that a patient is addicted. They're two completely separate, separate buckets. Often go hand in hand, but they're two different processes. Hyperalgesia, so this is as increased opioid doses, as the dose increases over time, patients may become more sensitive to pain. And so, especially if doses are increased too quickly or just at very high doses. And then there's a lot of pain, very little stimulus. There's physical dependence. So that is when a patient actually goes through withdrawal after they're given either like a naloxone or the dose is stopped quickly. Giving too much naloxone is a thing, and precipitating withdrawal that way is the only way that opioid withdrawal can actually injure, kill a patient. They may wish that they're dead during withdrawal from opioids. It's very, very, very unpleasant, but it's not going to kill them. Unless potentially very small risk in giving way too high doses of an opioid reversal, naloxone, and then reversing all of it at once, that can cause harm. Addiction, so this is when we get into the pattern of behaviors that's ongoing substance use, despite the fact that they know there's harmful consequences to health and relationships. So they know that they shouldn't be doing it. They know that there's actually negative consequences going on in their life from it, but they can't not do it. Pseudo addiction is incredibly similar, but it's because they're doing those same behaviors because they're actually in pain. And it's very, very difficult to treat pain in somebody who's also addicted because there is crossover. You don't not treat pain in somebody just because they have addiction. You still need to treat their pain. Guidelines for opioid use doesn't really change much, but opioids are not preferred for chronic therapy. Perfectly fine for acute and severe pain. Immediate release are preferred because of the risk of overdose. Longer acting products are can be taken. They're very high doses, so they can be more easily taken too many at a time and actually get to those very high doses that are dangerous, as well as the ability to potentially alter formulation. So a long acting ends up being a whole lot in a very short acting form. Again, using lowest dose, shortest duration, and then avoiding with benzodiazepines when you can, especially for somebody that's going home. In-house during a procedure, and you need some anxiety as well as pain control using both, but not sending somebody home on both of them. Some red flags. So somebody who already abuses alcohol or illicit drugs, some sort of substance abuse, having disruptions of work, family, and social life, doctor shopping, so going around lots of places. The prescription drug monitoring programs or PDMPs helped a lot with this because now physicians, healthcare providers, pharmacies can all see everywhere a patient has gotten a prescription for an opioid. And so you can't go everywhere and get prescriptions from all over the place. Having lots of dose increases, particularly in a short time period. Anybody who's caught injecting something that is supposed to be taken orally, stealing medications from somebody else, purchasing somebody else's medications, as well as forging prescriptions. Okay, just about there. For sedatives, you want something that's quick, that you can titrate, something that also helps with anxiety as well as pain. Unfortunately, there's not a lot that do both. And then something that leaves the system quickly and recovers completely. The scale for agitation and sedation goes from like 0 is like normal. Positive numbers get to incredibly angry and combative, to negative numbers being like completely cannot arouse. Depending on a procedure, there may be different points. So maybe you just need them a little bit drowsy, or may need them in deep sedation and actually under full anesthesia. So general principles, giving analgesia ahead of time before you know something that's going to be painful. Opioids are actually first line for severe acute pain. Notice or see if there's neuropathic pain present, because that can impact the overall pain the patient is feeling. Give them something so they can go to the bathroom. And you don't want them to have amnesia from high doses. You want them to have some relief of their anxiety, but not be unaware of everything that happened. Separately, anesthesia. So the stages of anesthesia, we have some amnesia and analgesia, which can go to up to patients that have some excitement and delirium, to surgical anesthesia. And this is where surgical anesthesia, this is the level that's needed for surgical procedures. But if you go too far, then that can lead to respiratory arrest. You can also have anesthesia overdose, which essentially is there's too much anesthesia, so there's not enough oxygen. And so you need to just give them pure oxygen to replace what they have not been receiving. I like to give an anxiolytic as well as an antiemetic ahead of time, then induce the anesthesia with an IV. Start the drug that's going to be used for the actual maintenance. That's going to go on during surgery, and we're going to start inhalation. Again, maintaining that stage 3 of surgical anesthesia. And then we stop the maintenance. You still want to maintain pain control though, and there's a good chance the patient may need antiemetics. Kind of going just a scale of all the different types and routes, as well as the grading classification. So benzos, sedation, anxiety, there's no pain relief. Binds GABA. Common ones, so diazepam, lorazepam, midazolam, those are probably the ones you'll see the most. Orally, it could be diazepam, alprazolam, and lorazepam, most likely. No analgesia. So giving a benzo might make them feel less worried, but it's not going to actually give them pain. If somebody is on an opioid, this can make their respiratory depression worse, because it relaxes everything, including your muscles. And so essentially you're like slumped forward and almost pinch your windpipe shut, but now you also don't have the feedback of your carbon dioxide going up. And so you don't wake up and try and breathe again. Without an opioid, you will not have respiratory depression from a benzo, because that increase in carbon dioxide causes you to kind of startle and change positions. Opioids, again, you're going to have to be in combination with an anesthetic, because they do not actually they give the analgesia, but not the like anxiety or the actual anesthesia. Propofol works very similarly to benzos, but is a little bit special and different. Again, though, no pain control. It can cause decreases in blood pressure and heart rate. Barbiturates, phenobarb is the most common that's available anymore, and we really don't use it anywhere. And then the inhalational anesthetics, ranking them from potency from anywhere nitrous oxide to halothane. Reference for vital sign monitoring. And then levels. So depending on what percentage of nitric being used, can be anywhere from like the anxiolysis and sedation to like very deep sedation. You don't want to go too far. And then like general anesthesia is going to be further down. Nitrous oxide kind of works in lots of different ways. The big effect here is that is through GABA, as well as there's some opioid activity. It does cause analgesia, which is good. We like to have analgesia as well as sedation. Kind of not really asleep, but you're not really with it. So the dizziness, euphoria, hallucinations, seeing things that aren't there, or hearing. And then a distribution of different effects somebody can feel based off of the different percentages.
Is it addicting then?
I wouldn't say that it's addicting in the same way as an opioid, but in the same way as a lot of addictive behaviors. So a lot of illicit substance abuse, regardless of the type of substance, is often done repeatedly. Like, but it's a different, it's not physical dependence. It's more of a psychological dependence. Yeah, that's it. And then the last one was the pharmacokinetics. So timing, it's really fast, and it doesn't last like a super long time. It's not metabolized. You essentially are breathing it back out eventually, as well as some just like comes out of your skin. But most of it ends up being exhaled after it, goes around the body through the blood system. That's sorry, that last bit.
Thank you so much. That's a lot of information. I'll stop the recording too. I saw Etodolac on one of them. So I was curious about that because